So when I'm looking at patient factors such as their CD4 and their viral load as they enter into care, one of the things we've known throughout the history of HIV is that those patients who present with lower CD4 counts, so those under 200 or those with higher viral loads, more than 100,000, are really always what we call the problem areas, because they're the ones that we know that are harder to treat. And if you have patients who are presenting or they're late to care or late to entry, they're the ones you're concerned about. So again, I want to make sure they have a really potent regimen for that group. Because again, I'm worried, why did this person come into care so late? And I'm worried, are they going to have problems with adherence? So I want to make sure they have a really potent regimen. But those CD4 and viral loads, and no matter what regimen you use, even a very good, highly efficacious regimen is still going to perform less than it will not perform as well in someone who has a low CD4 count, high viral load, compared to those with a higher CD4 and a lower viral load. So in terms of comorbid conditions, I think one of the things we're seeing now in the HIV epidemic is a shift from what we used to see as HIV wasting syndrome, where patients were coming in, they had lost weight, they were very cachectic, and now we're seeing just the opposite. We're seeing an uptake and an increase in the number of patients we see who are labeled as obese. And with the obesity coming all the problems of diabetes, hyperlipidemia, hypercholesterolemia, and all those other factors, maybe heart disease. So we sort of seen a shift, and it's really about how to get patients back to their normal health. And the big question, I think, for all of us is this shift in weight gain, is it related to the virus itself? Is it related to a return back to health? Or is it related to the drugs? And this is something that's really been looked at from the beginning when we're starting to look at drugs and when patients start to gain weight. So they're the biggest comorbidities. But again, other things I see, we definitely know that there's an increase in cardiovascular disease and HIV, with a twofold increase in the number of events that you see, high blood pressure, and let alone other cases such as hepatitis C co-infection, hepatitis B co-infection. So we do see quite a number of comorbidities, and I think the biggest problem is, how do you manage those comorbidities in conjunction with HIV and prevent the least number of drug-drug interactions and stability? So every patient who is diagnosed with HIV will have a baseline genotype testing. We'll have baseline genotype testing done. Typically that genotype testing is done for the NRTIs, the NNRTIs, and the protease inhibitors. At this point, we don't do it for the integrase inhibitors because the rate of integrase resistance is about 0.04%. So we don't really need to do it yet, so we can feel comfortable. Where we see the most number and the highest number of transmitted drug resistance is in the NNRTI class. And again, that was an issue when we were using a lot of NNRTIs, but now we've cut down on that. So again, I can feel confident if I'm drawing a genotype today, I can start a patient on treatment because, again, I'm going to use an integrase inhibitor. The other class of drugs where you're able to get away without waiting for your genotype results to come back would be using a boosted protease inhibitor because, again, they're the two drug classes where we have the lowest level of transmitted resistance. When I'm concerned about adherence to the regimen, and there's a whole series of factors that go through my head as to who would be adherent. And I must say that when I'm looking at a patient, anyone sitting in front of me who I don't know, I feel the risk for non-adherence to a regimen. So it's always in the back of my mind. So I think now in 2018, 2019, we do have the ability to pick drugs that have high genetic barrier to resistance. When we're using things such as NNRTIs, unboosted protease inhibitors, or maybe the first generation integrases, we may have started out with a low genetic barrier and then we really blew part of that class, and we know with blowing resistance you get cross resistance. So I think now I feel pretty confident when I have someone in front of me. If I really am concerned about their adherence, I would use a second generation integrase inhibitor that's a high genetic barrier, as well as, or in addition, not in addition, but whether I would use one or the other, a boosted protease inhibitor. So I think that's really important, and it's one of the things I think when you first meet a patient, it's really about doing a thorough history on that patient to find out, who they are, what other type of medical problems they have, what other comorbidities are involved, because then I can limit in my head what are the drugs that potentially they could work with. And then I think talking with the patient, I think it's really important. The biggest part of it is, what does the patient want? Because I can want 3 drugs once a day, and the patient may want 1 drug once a day. So it's really important to sort of work with patients, make sure they understand what are they interested in, and then really come together with a regimen that really will work for them.